Hello, everyone. Today I'll be talking about the trauma-informed care principles. Specifically, I'll be looking at the Veterans Health Administration. And throughout this presentation, I'll specifically be focusing on veterans recently deployed in Afghanistan and Iraq. And you might see OEF or OIF, and that stands for Operation Enduring Freedom and Operation Iraqi Freedom. So those are just the names applied to Afghanistan and Iraqi veterans. So what is trauma? Trauma is an emotional response to incredibly adverse situations, and I'll be looking at the types of trauma that veterans are experiencing, such as combat, sexual assault, natural disasters, and terrorism. And it impacts a person's ability to cope. It can cause feelings of helplessness, a diminished sense of self, and an inability to feel a full range of their emotions. And it's important to note that not everyone that has trauma can develop PTSD. If trauma symptoms last for only a few weeks, then it can be called acute stress disorder. Symptoms lasting for more than a month can be suggestive of PTSD. Veterans are at a high risk for PTSD, and it's shown that about 11 to 20% of OEF, OIF veterans develop PTSD. And listed are all the criteria that need to be met in order to classify someone having PTSD. One of the common impacts of traumatized veterans is that they are disproportionately affected compared to non-veterans for homelessness and addiction. Some of the recent estimates suggest that about 58,000 veterans are homeless, with about 70% of them experiencing substance use addiction, and nearly half of homeless veterans experience mental illness. Veterans have greater odds than non-veterans of experiencing homelessness, and this can increase a higher risk for re-traumatization due to increased exposure to HIV, other illnesses, mental health illnesses, criminal behavior, and incarceration. There was a study done by Eugene M. Dunn, and it wanted to contextualize the experience of homeless male veterans compared to their non-veteran counterparts. And it's been shown that veterans are 6 times more likely to report addiction, 4 times more likely to report current mental health problems, 2 times more likely to report physical health symptoms, greater odds of visiting an ER, and they have higher rates of divorce. And it's been shown that multi-stage housing programs can be useful for helping veterans reintegrate into independent living despite their substance use and mental illness. And for veterans who are previously religious, it's been shown that faith-based programs can improve housing and clinical outcomes. Another common impact of traumatized veterans are disrupted familial relationships. And some of the themes that I've read about is emotional numbing and emotional withdrawal. And this can cause a vicious cycle of not seeking the social support that one needs in order to heal from their trauma. Veterans with PTSD are also more likely to be perpetrators of domestic violence than veterans without PTSD. And families with veterans suffering from PTSD, they have an increased disruption in their functioning of family cohesion and parenting satisfaction compared to families without veterans suffering from PTSD. In this slide, I'd like to talk about vicarious traumatization. And this can apply for therapists, not just working with veterans, but clinicians face a certain type of pressure and a certain type of frustration when they deal with traumatized veterans. There was a study shown that OEF, OIF veterans attend fewer psychotherapy sessions, and they miss more appointments, and they drop out at a higher rate compared to veterans from other campaigns. And this can be incredibly stressful for clinicians, as having disrupted meetings, not meeting the adequate amount of dosage for treatment can, sometimes decrease the level of progress that veterans may be seeing. Veterans with a high risk of redeployment can cause another chance for re-traumatization. And there's an increased strain on clinicians who must also take into account the comorbidity of veterans, such as traumatic brain injuries, aggression, suicidal ideation, homelessness, substance abuse, and depression. There was a study done that shows that clinics using evidence-based practices can lessen the blow of vicarious traumatization, because having a more manualized, clear treatment protocol can serve to lessen ambiguity, and it decreases emotional involvement in treating trauma victims. And therapists can also protect themselves against this type of traumatization through their own religious beliefs and their own spirituality, social support, self-care, and having a balanced workload is really important in managing their own self-care. Another symptom of vicarious victimization is burnout and countertransference. This is just when the therapists that are own unresolved unconscious conflicts can cause therapists to confront their own sadistic and retaliatory wishes. I read about how therapists treating veterans experience their own PTSD, and they experience their own nightmares after just listening and treating heavy caseloads of veterans. And this can also include survivor guilt, irritability, alienation, and increased aggression. Secondary victimization is when people close to the victim may experience symptoms of trauma similar to the victim. And there was a study done showing that about a third of therapists working with the military developed secondary traumatic stress, and about a fifth of therapists met all 5 criteria for PTSD just due to their indirect exposure to trauma. Like I said before, the VHA, the Veterans Health Administration, has been very focused on pushing for more evidence-based practices, and I'll be talking about one. It's called prolonged exposure. Prolonged exposure is a manualized treatment protocol consisting of psychoeducation, self-assessment, and repeated exposure to situations. And it's a repeated, prolonged, imaginal exposure to traumatic memories, followed by processing or discussion of the memories. A study that I'll be talking about today showed that about 65 veterans suggested that prolonged exposure is as effective for treating PTSD as other randomly controlled trial studies. And as you can see, the mean for the PCL and BDI shows that there's a clinically and statistically significant level where before treatment, they come in with a higher score, and after treatment, it's been shown to decrease their PTSD symptoms. The study also noted that the treatment retention rate was pretty adequate, meaning that prolonged exposure is a very tolerable treatment for veterans. Another evidence-based technique or practice that I'll be talking about is emotional freedom technique. And this will be specifically looking at the improvements in their symptom assessment and their post-traumatic stress disorder checklist. And exposure therapy is used in EFT, and it's paired with cognitive and somatic elements. So the cognitive element is assessing the degree of distress on a scale of 1 to 10, while pairing that with exposure statements and self-acceptance statements. So this is called setup statement. One example is when a veteran client may be saying, even though I wanted to vomit, when I think about that time I had to pull my buddy's decomposing body from the rubble, I fully and completely accept myself. A somatic element of EFT consists of tapping 12 points on the body with their fingertips, 5 on the head, 2 on the torso, and 5 on the hand. After assessing their degree of distress, the EFT treatment begins by repeating the setup statement 3 times while tapping the 12 points on the body 5 times each. And after a round of tapping, the degree of distress is reassessed. And if you can see on the table, the group's average score for the PCLM was 62 before treatment and was 23 after treatment. And follow-up for 30, 90 days and for a year showed that it's maintained that decreased level. And it's important to note that a score of about 50 is considered PTSD positive. So the organization that I'm talking about, the Veterans Health Administration, has the primary responsibility for providing care for traumatized veterans. And I'll be specifically looking at how specifically they can incorporate trauma-informed care principles in their organization to better support veterans. This has become increasingly important because there has been an increased demand for services, and many VHA providers have become overwhelmed and unable to provide adequate care due to difficulties in scheduling and due to heavy caseloads. It's been shown in a study that even in the community-based level, a lot of clinicians are not equipped to handle the needs of veterans. A national survey showed that about only 13% understood the unique experiences, issues, and the needs of veterans. So one TIC principle is safety, and this can include practical information and advice such as avoiding closing the door without the veteran's consent, avoiding having the client close their eyes for a technique without their consent. And this can also include avoiding procedures that require the veteran to recount traumatic events multiple times for the sake of paperwork or for the sake of other staff. It's important to make sure that you guys are on the same level. The therapist and the client has to maintain a sense of safety within their treatment. And this can lead into the next principle. It's called trustworthiness. Trustworthiness can only be earned through clear communication and honest behavior between the client and the therapist. Treatment planning should be used to meet the veteran's needs rather than the veteran to shift his or her needs to accommodate the organization's practices. The third principle is choice and collaboration. So the evidence-based practice movement emphasizes 3 pillars for selecting clinical procedures: having the best scientific evidence, clinical judgment and expertise, and 3, the patient's own preferences and values. Choice and collaboration emphasizes that veterans chooses and has a part in wanting to choose the type of treatment that they'll be getting. The client acts as the expert on himself or herself, and the therapist acts as the provider of the expert clinical procedure. It's important to maintain the veteran's feeling of personal control and agency to address their own individual needs. And this can also increase the therapist's cultural sensitivity and creativity, because every veteran has their own specific preferences, their own degrees of distress, their own availability to resources, and they have their own triggers. The last principle I'd like to talk about is empowerment. Community-based providers should take time to cultivate relationships with governmental organizations such as the VHA. And if a veteran is not using VHA and they're paying for their own healthcare out of pocket, the therapist can advocate and empower their client by reaching out to VHA providers and coaching the veteran to advocate for themselves within the system. So having all these principles in mind, the Veterans Health Administration can incorporate these to increase the level of care for veterans. And here are my references. Thank you for listening.